Most people believe that a heart in serious trouble announces itself dramatically. Crushing chest pain, a left arm that goes numb, a sudden collapse that leaves no room for ambiguity. That is the heart attack of television and film. That is the cardiac emergency everyone recognizes. But here is what most people are never told. A significant proportion of the most serious cardiac events, the ones that kill without warning, the ones that arrive without a prior hospitalization, without a prior diagnosis, without a single clear red flag that anyone acted on, are preceded by symptoms. Quiet symptoms, nighttime symptoms, symptoms that occur in the dark, when the house is still and there is no doctor present and no one to say, "This matters. This is serious. This is your heart sending you a warning you cannot afford to ignore." 6 of those symptoms are what this video is about. 6 things that can happen at night, in the hours between when you turn off the light and when your alarm goes off, that represent your heart communicating in the clearest language available to it that something is seriously wrong. 6 symptoms that millions of adults over 60 have experienced, dismissed, and gone back to sleep through. And in some of those cases, that dismissal was the last medical decision they ever made. I am not telling you this to frighten you. I am telling you this because fear without information is paralysis. But information, the right information, delivered clearly and completely, is the thing that saves lives. And the information in this video is the kind that belongs in every home where an adult over 60 goes to sleep every night. My name is Dr. Favor Clinton. I have over 10 years of clinical experience in internal medicine and cardiovascular medicine, and I have sat with families after cardiac events that did not have to end the way they did because the warning was there and nobody knew how to read it. Today, we change that for you, starting now. Before we go through the 6 symptoms, I need to explain a specific feature of nighttime cardiac symptoms that makes them both more significant and more likely to be dismissed than their daytime equivalents. During the day, if you feel chest tightness, breathlessness, or an alarming palpitation, you are in a context where help is accessible. You can call someone. You can drive to a clinic. The daylight, the activity, the proximity to other people, all of these create conditions in which a symptom is more likely to be taken seriously and acted upon. At night, that context dissolves. You are alone in the dark. You are disoriented from sleep. The symptom feels less real, less urgent, less connected to the clinical language of cardiac emergency. You tell yourself it is a dream, or indigestion, or the position you slept in, or the meal you had. You turn over. You go back to sleep. And the symptom that deserved immediate attention gets filed under probably nothing and is forgotten by morning. There is also a physiological dimension to why nighttime symptoms are particularly significant. During certain sleep stages, particularly during REM sleep, the cardiovascular system experiences fluctuations in autonomic tone that can trigger arrhythmias, anginal episodes, and blood pressure surges in people with underlying cardiac vulnerability. The night is not a cardiovascular rest period in the absolute sense. For a heart under stress, it is a period of dynamic physiological challenge that can surface problems that daytime activity masks. The 6 symptoms I am about to describe are the ones that surface specifically at night and that carry the most clinical weight for cardiac risk. Know them, remember them, and if they happen to you or to someone you sleep next to, know exactly what to do. I want to tell you about a patient I will call Octavia. Octavia was 70 years old when her daughter brought her to see me. Octavia had not come of her own accord. Her daughter had insisted, with the particular combination of love and alarm that adult children feel when they sense something is wrong with a parent and cannot get the parent to agree. Octavia was a retired civil servant, independent, pragmatic, and deeply resistant to what she described as making a fuss. For the preceding 3 months, she had been experiencing 2 of the 6 symptoms I am about to describe on an almost nightly basis. She had not mentioned them to her GP. She had not mentioned them to her daughter until a chance remark one morning had prompted the urgent conversation that brought her to my office. Her reasoning for dismissing the symptoms was the same reasoning I hear from patients constantly. I did not want to worry anyone. I thought it was probably nothing. I did not want to end up in hospital over something that turned out to be indigestion. I was going to mention it at my next annual appointment. Her next annual appointment was 4 months away. When I examined Octavia and ran the investigations her symptoms warranted, I found significant 3-vessel coronary artery disease. 3 of the major arteries supplying her heart were substantially narrowed. She required urgent intervention. Her cardiologist told her, with the kind of careful honesty that good cardiologists practice, that the window in which she had presented was the right one, that another few months of dismissal might have produced a very different outcome. Octavia's daughter asked me afterward what the signs had been. I walked her through both of them in detail. She said, "If I had known that, I would have brought her in months ago." That is the conversation this video is designed to enable. For you, for your family, for everyone in your life over 60 who goes to sleep tonight in a house where these 6 symptoms might occur and where nobody has ever been told what they mean. Let me be precise about what I mean by discomfort, because the word chest pain is one that leads people astray. Cardiac chest symptoms are not always pain. Many patients, particularly women and older adults, describe them as a pressure, a heaviness, a tightness, a sensation of something sitting on the chest, a feeling of constriction that is not sharp or stabbing, but that is distinctly uncomfortable and distinctly located in the chest or the upper abdomen. When this symptom wakes you from sleep, the cardiac significance is elevated significantly compared to the same symptom occurring during exertion. Nocturnal cardiac symptoms of this type are called rest angina or variant angina, and they represent a different and in some ways more urgent category of cardiac ischemia, reduced blood flow to the heart muscle, than the exertional angina that occurs during activity. Rest angina can occur because of coronary artery spasm, a sudden tightening of an arterial wall that temporarily reduces blood flow to the heart muscle without a fixed blockage. It can occur because of plaque rupture with partial clot formation that reduces flow intermittently. And it can occur because the overnight shift in autonomic tone during certain sleep stages reduces the heart's oxygen supply below the threshold needed to maintain comfortable function in a heart with significant coronary artery disease. Octavia's first symptom was this one, a pressure in the center of her chest that woke her from sleep on average 3 nights per week for the 3 months before her daughter brought her to see me. It lasted between 5 and 15 minutes and resolved on its own. She had attributed it to acid reflux. She had started taking an over-the-counter antacid before bed and had noted that it did not seem to help, which she attributed to the antacid not working, rather than to the symptom not being acid reflux. Any chest discomfort, pressure, tightness, or heaviness that wakes you from sleep warrants same-day medical evaluation. Not tomorrow, not at your next scheduled appointment. The same day. If it is accompanied by sweating, breathlessness, arm pain, jaw pain, or nausea, call emergency services immediately. This symptom has a specific medical name, paroxysmal nocturnal dyspnea, and it is one of the most specific and most serious nighttime cardiac warning signs that exists. It presents in a very particular way. You are asleep. Suddenly you are awake, not gradually, but abruptly, with an urgent, alarming sensation of breathlessness. You cannot get enough air lying down. You need to sit up, to put your feet over the side of the bed, to get to a window or a fan. Within a few minutes of sitting up, the breathlessness eases. You feel better. You wonder if you were dreaming. You go back to sleep. This pattern, sudden nocturnal breathlessness that is relieved by sitting up, is caused by acute pulmonary congestion. When the heart's left ventricle is under stress and its filling pressure rises, fluid seeps from the pulmonary capillaries into the lung tissue. When you are lying flat, gravity distributes that fluid throughout the lungs, impairing gas exchange significantly enough to wake you gasping. When you sit up, gravity draws the fluid toward the lung bases, relieving pressure on the upper lung tissue and restoring more adequate breathing. Paroxysmal nocturnal dyspnea is not a minor cardiac symptom. It represents significant elevation in left ventricular filling pressure, which is a direct indicator of cardiac stress that has progressed to a point requiring urgent clinical evaluation. If this has happened to you once, tell your doctor at your next appointment and ask for a cardiac assessment. If it is happening regularly, do not wait for a scheduled appointment. Call your doctor tomorrow morning. We discussed palpitations in the context of silent cardiac stress in our previous video, but palpitations that occur specifically during sleep, that wake you up, or that cause significant anxiety when you lie down to sleep at night, carry a specific additional weight that deserves its own discussion. Atrial fibrillation, the most common serious cardiac arrhythmia in adults over 60, frequently initiates or worsens during sleep. The shift in autonomic tone during the night, particularly during REM sleep, can trigger the disorganized electrical activity of the atria that characterizes this condition. People describe being woken by a racing, irregular heartbeat, a pounding that feels frantic and disorganized rather than simply fast, that may last for minutes to hours before self-terminating. Atrial fibrillation is not merely uncomfortable, it is a significant stroke risk factor. The disorganized atrial activity allows blood to pool in a small pouch of the left atrium, called the left atrial appendage, where clots can form and subsequently travel to the brain. The stroke risk in people with undetected and untreated atrial fibrillation is 5 times higher than in people without the condition. The challenge is that because nocturnal atrial fibrillation is intermittent and self-terminating, a standard ECG taken during a clinic appointment will frequently be completely normal. This is why I recommend specifically to any patient who reports waking with palpitations that their doctor consider a wearable cardiac event monitor or a 24 to 48-hour Holter recording. The rhythm must be captured during an episode to be diagnosed, and it must be diagnosed to be treated. Night sweats are common in older adults and have many causes, including hormonal changes, certain medications, infections, and thermoregulation changes associated with aging. I am not telling you that every episode of nighttime sweating is a cardiac emergency. What I am telling you is that there is a specific pattern of night sweating that carries cardiac significance, and that is consistently missed because it is attributed to everything except the heart. The cardiac variety of night sweating tends to occur in association with one of the other symptoms on this list. It accompanies chest discomfort or breathlessness during a cardiac event. It occurs during episodes of nocturnal arrhythmia. It can be a manifestation of the sympathetic nervous system activation that accompanies acute cardiac ischemia, reduced blood flow to the heart, even when the ischemia is not severe enough to produce obvious chest pain. The sweating itself is the body's stress response, activating in response to a cardiac event that may not be consciously perceived as an emergency. The heart is in distress. The adrenal system responds. Sweating is one component of that response. When it occurs in isolation, without other symptoms, it is less likely to have a cardiac cause. When it occurs in combination with any other symptom on this list, the probability of a cardiac explanation rises significantly. If you wake with unexplained sweating that is not explained by room temperature or bed coverings, and if that sweating is accompanied by any chest sensation, breathlessness, or palpitation, however mild, do not dismiss the combination. The combination is the signal. Each individual component might be explainable alone. Together, they require urgent medical evaluation. This is the symptom that catches people most completely off guard. Jaw pain, tooth pain, a dull ache in the shoulder that seems to have no muscular explanation, a heaviness in the upper back. None of these, on the surface, suggest the heart, and that is precisely why they are so dangerous when they occur during a cardiac event. The mechanism is called referred pain, and it is one of the most important concepts in cardiac symptom recognition. The heart shares its nerve supply pathways with several other structures, including the jaw, the teeth, the left arm, the left shoulder, the upper back, and the upper abdomen. When the heart is ischemic, when its blood supply is compromised, the pain signals it sends travel through shared nerve pathways and are interpreted by the brain as originating in those other structures rather than in the heart itself. This is why the classic description of a heart attack includes left arm pain, and why jaw pain or tooth pain that awakens a person from sleep, particularly in combination with any sensation of pressure or discomfort in the chest, is one of the most under-recognized but well-documented presentations of acute cardiac ischemia in older adults. Octavia's second symptom was this one. She described waking occasionally with a dull ache in her lower jaw that she could not explain. She had seen her dentist, who found nothing. She had attributed it to grinding her teeth at night and had purchased a mouthguard. The mouthguard, predictably, had made no difference. Unexplained jaw pain or tooth pain that wakes you at night, that has no dental or muscular explanation, and that resolves within minutes to half an hour of waking, is a symptom that requires a cardiac evaluation. Not a dental second opinion, a cardiac evaluation. That conversation saved Octavia's life. It can save others. I include this symptom last because it is the one that people find most difficult to describe to their doctor and most reluctant to report. It sounds subjective. It sounds dramatic. It sounds like the kind of thing that might prompt a referral to a mental health professional rather than a cardiologist. And for those reasons, it is one of the most consistently underreported and most clinically significant symptoms on this entire list. There is a specific and well-documented phenomenon in cardiac medicine called a sense of impending doom that accompanies certain categories of acute cardiac events. It is described in the medical literature. It is reported consistently by patients who survive cardiac events and are interviewed about their prodromal symptoms, the symptoms they experienced in the hours and days before the main event. The mechanism is not fully understood, but the most credible explanation involves the activation of specific autonomic pathways during cardiac ischemia that produce an overwhelming and entirely physical sense of fear or impending death that is independent of any conscious thought process. It is not anxiety about the future. It is not fear of a known threat. It is a visceral, physical sense of wrongness that the body generates in response to a cardiac event. When this sensation wakes you from sleep, when it is sufficiently intense to bring you out of deep sleep with a feeling that something is seriously wrong, and particularly when it is accompanied by any other symptom on this list, it is not a psychological symptom. It is a cardiac one. Treat it as such. Contact emergency services or have someone take you to an emergency department. Dismissing it as anxiety or as a vivid dream is the most common and most dangerous response to this symptom. The patients who survive to tell their cardiologists about it are the ones who trusted the feeling enough to act on it. That trust is the thing this video is trying to give you before you ever need to use it. Let me bring this all together into the most practical guidance I can give you, because information that does not translate into action does not save lives. Tonight, there are two things I want you to do. The first is to read through the 6 symptoms one more time and think honestly about whether you have experienced any of them in the past several months. Chest discomfort, pressure, or tightness that woke you from sleep. Sudden breathlessness at night that required you to sit up to relieve it. Palpitations at night that woke you or caused significant anxiety. Unexplained sweating not explained by room temperature, particularly in combination with any other symptom. Jaw pain, tooth pain, or unexplained upper body discomfort that woke you without dental or muscular explanation. And an overwhelming sense of doom or impending death that brought you out of sleep. If any of these has occurred once, tell your doctor at your next appointment and ask for a cardiac assessment to be included in the evaluation. If any of these is occurring regularly, do not wait for your next scheduled appointment. Call your doctor's office tomorrow morning and describe the symptoms specifically. The second thing I want you to do tonight is share this information with the person who sleeps in the same house as you, your spouse, your partner, your adult child, whoever is closest to you at night. Because if these symptoms occur while you are asleep, you may not be the person who needs to act. They may be. And they can only act correctly if they know what to look for and what to do when they see it. The action for any of the 6 symptoms occurring acutely is this: chest discomfort or pressure, sudden breathlessness, jaw pain, or the overwhelming sense of doom. Call emergency services immediately. Do not drive yourself. Do not wait to see if it gets better on its own. Do not take an antacid and lie back down. Call emergency services, chew an aspirin if you have it and are not aspirin allergic, and wait for help to arrive. I want to hear from you in the comments. Have you experienced any of these 6 nighttime symptoms and dismissed them as something else? And was there a specific symptom on this list that surprised you as a cardiac warning sign rather than something else? Your honest answer in the comments helps me understand what this community needs most, and it may be the thing that prompts another viewer to recognize a symptom they have been ignoring. If this video gave you something important today, something that goes beyond information into the territory of genuine preparedness, please share it. Share it with everyone in your life over 60. Share it with the partners and adult children of people over 60 who might not watch a health video themselves, but whose loved ones would benefit from them knowing this. The 6 symptoms in this video are the kind of knowledge that belongs in every household. Getting it there is how lives are saved. Subscribe for more honest, research-grounded conversations about protecting your cardiovascular health after 60. Next time, we are going to talk about why your blood pressure is higher in the morning and what to do about it before 8 in the morning. That video connects directly to everything we discussed today and gives you specific morning actions that protect your heart during its most vulnerable daily window.